We've just started the recording so that we may post it. I would love this to be as interactive as possible, and I encourage you to just raise your hand or interrupt. Dave, I'm going to ask you to help me facilitate chats, or if you see a hand come up that I can't see while I'm presenting.
Happy to do so.
I'm Kalli Varaklis. I am the designated institutional official at Maine Medical Center, Maine Health. The role is basically overseeing all of the residency and fellowship training programs, or Director of Graduate Medical Education. I'm also the principal investigator on the MERGE Collaborative grant, and the first up to offer what is going to be a monthly grand rounds sponsored by the MERGE Collaborative and the Building Maine programs. And the goal of these sessions are really to be able to provide outreach teaching and faculty development that are sort of very short, relevant, and relevant not only to GME, but really to anybody who teaches in the outpatient setting. I have no relevant financial relationships with any ineligible entities, and sadly with any eligible entities. The only disclosure is that the MERGE Collaborative is funded by a generous grant from the State of Maine Department of Health and Human Services, which we're very grateful for. To claim continuing education for this session, you can just text the activity code, which is 90615, to this telephone number on your cell phone, and you will receive a reply text. Dave will put this in the chat so that you also have this information if you can't get it until as I continue, and it will be my last slide as well during the question session. So the objective today is really short and sweet. Why bother teaching at all? What are the barriers to teaching in the outpatient setting? And I'm going to introduce just one best practice to be able to precept and do so in a time-sensitive manner that meets the needs of the learner and the patient. And then I'll end with a couple of quick tips on giving good feedback. So the first question is, why even bother teaching, right? Everybody is busy. The demands of medical record keeping, the MyChart or the interactive patient portal are increasing. There's quite a bit of literature on this, but really, many faculty report improved professional satisfaction and actually decreased burnout. It breaks up the monotony of 100% patient care. There's a great opportunity to role model, to share expertise. Having learners is a definite recruitment benefit, and for folks in areas that are more challenging to recruit for, this is a benefit. It's an extension of our commitment as physicians and healthcare providers to patient care, right? By helping to train the next generation well. There's always reciprocal teaching and learning. For those of us who've spent a career working in education, I learn from my learners as much as they learn from me. And when it's done well, and we have a grand rounds in a couple of months, it actually can help with time management and even reimbursement in the outpatient setting, particularly with the GME learners who can put in orders, help write notes, etc. However, there are barriers for sure to teaching in the outpatient setting and really in all settings. And the first one is time, overwhelmingly. But there's also uncertainty about how to teach, how to control the teaching interaction so that you are able to get through patients in a timely way. Some folks have expressed concern about, gosh, I need to keep up with the latest literature, and feeling that that's a barrier. Telemedicine is fantastic for patient access, equitable access to care, but it is a little bit more challenging to incorporate teaching, and we'll be giving a grand rounds in the future about how to really teach with telemedicine. And then the barrier, again, is time, and whether it's perception of not enough time, and also not a great understanding perhaps of how to manage the teaching so that it is additive to the day, not a burden. So the bulk of this quick, or it's a education outreach, is to introduce one best practice for outpatient precepting in a time-sensitive manner. And there are 3 phases. There's preparing for the visit or preparing for the day of teaching. There's sort of teaching, sort of the big intervention, and then there's giving feedback. And what this does is it really helps you as the preceptor control the precepting in, again, a time-sensitive manner, but also doing it in a evidence-based medical education approach. So preparing for the visit or preparing for the day of visits, really the most important thing is to define the learner's role and the expectations you have of them. And I think this is where you really are able to control the whole day. So how many patients will they be seeing? Which ones will they be seeing? It's fantastic if you can engage the learner in this, because the learner may say, hey, I have seen these 3 patients last week, or I'd love to see them again, so that getting their input is super helpful. What is the flow of presenting? Do you want them to present depending on your model? When do you want them to present? For more junior learners, what part of the physical exam do you intend for them to do? And what part of the documentation are they responsible for? In this way, you can set expectations, and so the learner, it decreases their anxiety and uncertainty, especially if they're working with you for the first time, and can help you get what you need, help the learner get what they need in a patient-centric way. So example, you're going to be seeing 3 new patients today. I want you to go in, get a complete history in less than 15 minutes, during which time you may be seeing other patients, and do a heart and lung exam. When you're done, come and present to me and we'll do the pelvic examination together. A learner can appreciate this. They know exactly what they can do, when to get you, and what you don't want them to do with a particular patient. So that's really the majority of the preparing for the visit. Any questions with that? Pretty straightforward. Many of you are doing this already. The other thing that you can do, and you would expect most learners to come with some expectations, but this is example guidelines. So if you're working with a very, very early learner, or you're working with a learner who quickly demonstrates to you that they really don't know how to present an outpatient patient in the outpatient setting, you can use something like this to be able to, again, set presentation expectations. It really should be 2 to 5 minutes long. And the first sentence is, this is chief complaint, and my question is, should I prescribe antibiotics? The HPI should be about 50% of the total presentation time. Most preceptors are looking through the chart as our residents are presenting, and so you're looking at information as they're talking about the patient. And so if you, this is just there are other ones in the literature, so this isn't the only outline for presentation expectations, but it is a good one that can be applied to all levels of learners. So we've controlled as much as we can how the day is going to go. We've given presentation guidelines if needed. And now they've seen a patient, they've done what you've asked, and they have come and presented the patient in 2 to 5 minutes. And then this is the precepting part. So this is really the meat of this presentation. And it's a well-documented technique called the 5-minute precepting technique. And so after the presentation, after they have given you their assessment and plan, even if their assessment is all they can do, and they say, I actually don't know what to do for this patient. But after the presentation, there are 5 steps. The first one is to get the student to take a stand on their assessment and plan. Tom Guerin, the former internal medicine residency program director at Maine Medical Center, says, this is the statement that doesn't have a question at the end of it, but rather has a period. I think this patient has an exacerbation of their congestive heart failure, not with a question mark. So I think really get them to take a stand. The second step is probe for supporting evidence on why they think that, teach general rules, reinforce the positive, and correct errors or misinterpretations. And this 5-minute precepting technique is so popular because there's data supporting it, and it does align with big educational theories for all learners and for nurse education as well. So let's just take a few minutes to go through each one of those steps. So the first step is get that commitment from the learner. And this basically, you're forcing them or encouraging them to give you an assessment which really helps you get a better understanding of their clinical reasoning and the extent to which they can take objective and subjective data from the patient and make an assessment. It's incredibly important information for you. Be patient. There was a really interesting study done quite some time ago that says that the average wait time to get a student to respond is 1 second. And if you wait 3 seconds, you increase not only the student answer quality, but really the insightfulness that they're able to give for your response. And try and avoid putting in your perspective at the very beginning. Let them make that assessment. So what do you think is going on? I think this patient has a yeast infection, and this is what I want to do with it. Or they may say, I think it's a yeast infection, but I don't know what to do with it. So get a commitment from the learner and let them do that synthesis. Step 2 is really asking for supportive evidence. Why do they think this? So this is just asking about their thought process and can yield very important information about clinical reasoning. Why do you think that they have this ear infection? What evidence supports your diagnosis and what evidence does not support your diagnosis? And really, here is where you're at asking higher order questions, right? We're not asking them to reiterate just plain medical knowledge, but really focusing on how are they synthesizing the information and how are they applying their information from the literature and analyzing the situation. So really higher order tasks that we're expecting from these learners. The third step is to teach general rules, and this step is what makes it a teaching intervention. No more than 3 general rules. You can include foundational information, such as the CDC recommends offering STI testing at every visit for women under the age of 25. So a quick pearl, but it's very foundational to that visit. It can be a practical tip, right? Your experienced preceptors. Try examining the toddler in their parents' lap instead of on the table. They're not going to read that in a book or in UpToDate. They're going to get that from that practical experience that you have. Critical learning points. Ordering stool sample testing is critical for patients with intractable diarrhea. And another option is what's unique about this teaching interaction, right? So this elderly patient with otitis media, what's kind of unique about this is they probably have seen a lot of ear infections in young people who get fevers, but geriatric patients mount a fever much less frequently. And so that's sort of what the unique part would be in that kind of an interaction. So this should take 45 seconds to a minute. It's really fast, but this is when you are actually teaching. Step 4 is to reinforce the positives because they always did something right. It can be as simple like, I'm great that you remember to introduce yourself. I appreciated that you sat down before talking to the patient. I'm sure the patient appreciated you did not use medical jargon in your explanation. So it can be very broad, but start with something positive that they did. That was a great differential diagnosis. And then again, positives on their thought process and competencies. Your logic was spot on in coming to your diagnosis of influenza because of COVID, because of whatever the clinical situation is. So step 4, what did they do well? There's always something that they did well. And the last step is really correct errors or misinterpretation of facts. It's good to tell them, so I'm going to give you some feedback, and when they do your evaluation, they will remember that you gave them feedback. And really correct errors to influence future performance. So I've got an example here of coming to a premature diagnosis. So making a diagnosis really before they got all of the subjective, objective, and imaging data. And that's an important intervention. And then try to give them something to work on. So next time, try holding the forceps in your non-dominant hand to more accurately place your suture scissors. 2 very short pieces of feedback, but this is really what helps them improve the next time. And as we all know, all of our education is this feedback loop where we're doing something, reflecting about it, getting some feedback, and then doing it better the next time. And so this is an important step. So this is an example of putting this all together. The learner is telling the attending, I saw a 4-year-old in clinic. They've got a fever. They go through their history of present illness. They're talking about the past. They go to a physical examination. The child is febrile. They're talking about their examination. And so that's the presentation. And then we go right into the 5-minute preceptor model. Get a commitment. The attending, what do you think is going on? Learner. This kid has an ear infection and an upper respiratory infection, has made a commitment that that's what they think is going on. Step 2, the attending, probe for supporting evidence. The attending says, so what supports your conclusion? Why do you think they have an ear infection? The resident says, well, they've got ear infections in the past, they're complaining of ear pain, fever, and on physical examination, I think they have an ear, it's consistent with an ear infection. The attending, what would you like to do for them? I'd like to start amoxicillin after I review the patient's allergies. So step 2 is really, again, these are short interventions. So step 3, teach general rules. The attending, key features that I look for are this, 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 and this, because in the presentation, the resident was like unsure about a couple of findings. And then it can be relevant to the clinical encounter. So this is the first point is all about the physical exam. But the second point is a general. It's really important that we make sure that the discharge instructions are translated into the parent's primary language to make sure that the antibiotic is given at the appropriate intervals. That pearl can be applied to any patient situation in the future. So 2, in this particular case, just 2 general rules, never more than 3. Step 4, reinforce the positives. The attending, spot on. Your physical exam was great, as an example. And maybe a little bit more refined, you did not suggest doing a strep test, which was appropriate given the lack of pharyngeal erythema and complaints of a sore throat. So those were the 2 things that the attending thought the resident did well. And then step 5 is correct errors. Attending, you could have chosen to sit down before examining the child because the child was threatened. Even better, you could put the child in the parent's lap. So that's one sort of general feedback. And then the other error, you're correct. Amoxicillin is the correct antibiotic. However, the dosage you selected was not correct because you used kilograms and the weight in the chart was in pounds. Again, 2 errors that they will learn from specific to this case. Last thing, any questions about that? I just want to talk a quick tips about giving good feedback, but any questions about the 5-minute preceptor So, tips for good feedback, and we will have more presentations in the future diving down into this, but in general, the feedback should be relevant to the knowledge, skills, and attitudes that the learner is trying to achieve, right? That makes sense. If you're going to give feedback about the physical exam, it's going to be about the HENT and not about the abdominal exam. Teaching to the case is always the most effective. And so that's the step 3 with those pearls. And teach to the level of the learner. Your feedback and your teaching is really going to be very different depending on your learner. A brand new PA student or a brand new medical student, you will have a different interaction in your feedback with the resident where you really will give more refined feedback to get them to those competencies. Always offer concrete suggestions for improvement, if at all possible. Our learners are so craving of actionable feedback. They don't want to know, read more, or great job. They want to know, in your differential diagnosis, you missed this thing should have been on your differential diagnosis. You should go and read about that, and we'll talk about it tomorrow. Or in this example that I have here, very specific, switch your hands of your forceps and your scissors. But as concrete as possible, that is the most useful. And it really, again, encourage continuation of positive knowledge, skills, and attitudes. Wow, the patient really responded to you putting pauses when you were delivering bad news. It allowed her to collect her thoughts and have an opportunity to react. That's great feedback, right? The resident might not even have noticed that they were putting in pauses. So anything that you see is they're doing well, give them positive feedback. And again, that was step number 4. In general tips for giving good feedback, be very descriptive. And so when you did this, that happened. Try to give feedback in a private place if possible. Ask the learner how they thought they performed. In the Kolb experiential learning, we do something and get feedback, but the really important part is actually having the student reflect on how they did. I'll never forget, I did a delivery many, many years ago, actually at Boston City Hospital with a resident, and it was terrible. They did such a terrible job, and I was frantic to make sure that the baby didn't hit the floor. And I asked the learner how they thought they did. And they said, pretty good. The baby didn't hit the floor. And I was like, okay, let's talk about all the other things that happened. And it can give you a lot of input into their self-reflection skills. I think that really went well. Response from a student might be accurate. Why do you think it went well? But if it's really a mismatch between what you think happened, then that's an opportunity for that student to learn and practice self-reflection. Because once they become an attending or they're fully practicing, there's nobody necessarily overlooking them. And they need, as a lifelong learner, to be able to have that reflection. Focus on a behavior that can be modified as opposed to a personality trait. Personality trait, you are very abrupt. Okay, great. What do I do with that? As opposed to you ask the patient a question and interrupt it immediately after she started speaking. Okay, that is abrupt. That behavior is abrupt. But you've given enough feedback and specificity in that example that the resident or learner can say, okay, I'm going to ask a question, count to 5, and then let the patient have an opportunity to answer. So it's also hard for people to hear personality traits. You're very abrupt as negative, as opposed to you asked a patient and interrupted. It's still not great, but it's psychologically easier for them to deal with. Be very specific. Again, in this patient interaction, you did this. avoid, you always do that, you never do that, right? That's just good feedback for all of our relationships. And then finally, it's very important to allow the learner, as I started to say, to have some psychological space to hear it and to believe the feedback. So judgment is trying to be non-judgmental. Again, you are intimidating is not great. They're going to immediately balk from that. But the behavior is you stood and looked down at the person and interrupted many of their responses. That's a behavior that they can modify. And that is the presentation. And are there any questions or comments or any experience with this, that where it went well, where it didn't go well?
And Kalli, if you have a moment, if you could just stop sharing screen, because we're seeing a double screen. Thank you.
Hey, Kalli, this is Bud Higgins. Can you hear me?
I can. Thanks for joining us today, Bud.
Yeah, so great presentation, a great review of a very important part of teaching. We, as I've told you, we are now establishing teaching programs at Blue Water. I'm assuming that you're recording this, and this will be available for those who can't attend today?
Absolutely. All of the grand rounds, which will occur on the second Friday of each month, will be posted to the iHELP learning platform so that they can be referenced in an asynchronous way.
That's great. And perfect. David, I'm just asking, I'm sure it's in your prior responses to us, which are very professionally developed, but can you just remind us how to access that? I want to send this out to my colleagues in Blue Water Health.
I'll put it in the chat. There's two ways to get there: through the Merge Collaborative website or the Building Maine website, which is clinicalrotationsinmaine.com or .org.
Would you
Either
mind
way,
demonstrating
I'll put both.
that, David? I think we've got some time if you want to just pull it up to show.
Love
in addition.
to.
Thank you.
While Dave's pulling that up, I'll just remind people that we do have the opportunity to do some in-person learning too, if somebody would be interested in that. We have some funding that allows us to do that. So,
outstanding. So let's see. Here's the Merge Collaborative website. Can everybody see that on the screen? You'll see this big blue button, the iHELP-Maine, a statewide learning platform. You just click that, it brings you here, and this is the access point. So once you've arrived here, you say click here for access, and here we are. Kalli, if you want to briefly describe what we currently have in place.
Sure. The iHELP platform is a collaboration between the Merge Collaborative, which is as I said, the state-funded grant to help GME placement and rotations across the state, and the Building Maine, another state-funded grant, which is really looking at matching interprofessional learners from phlebotomy to medical students across the state. And I think as of yesterday, have placed 198 students through this matching platform. The two grants have combined to create this learning platform. And what we're really thinking about here is what are the resources that are useful to colleagues across the state, really thinking about rural education. So currently, there are two ways to access the information on this platform. We took some time and looked at 20 different professions across the state, and we went to their national organizations and found the competencies for each of these 20 different professions, and we harmonized them, and we think this is the first time that this has been done. We harmonized them into 7 different domains that really address everybody's competencies. And so you can see if you hit quality, safety, and practice improvement, which is the 4th of these domains, there are several subdomains, and if you hit the quality improvement, or the culture of safety, doesn't matter. You can see that we have 3 to 5 resources for each one of those subdomains with a quick sentence about what this is about and some learning objectives. And so as a preceptor, if you've got somebody who's working with you and you want them to learn about FISH method of analysis, you can look here and assign them these resources. The other way that you can access this material, if you could go back 2 clicks, we also organize the material in terms of the community health resources that are published. And these are sort of the top issues that are important for our rural communities in the state of Maine. So just another way to access the information. Coming soon, there will be another tab looking at DEI competencies, including rural, underserved, and DEI. So another way to access this information. And then a 4th planned way to look at it is through rural competencies. We understand that this is currently passive information, and so you have to go to the website. But today, just now, is our first foray into sort of active. So we will be doing, as I said, grand rounds monthly. The Department of Internal Medicine from Family Medicine from Maine Medical Center will be also offering virtual attendance at internal medicine grand rounds. Those occur weekly. We'll be advertising that and distributing the website, and that's a great opportunity for high quality grand rounds that now can be accessible through this website to anybody in the state. Other questions? Thanks for asking that, Bud. To count to 5. I've been told I don't wait enough to ask for questions. Many of you already know about the 5-minute preceptor. It's a great opportunity for a quick refresher. For those of you who haven't used it, it actually helps with what makes it difficult sometimes to precept, which is controlling the session. And so this is a very easy way, it's best practice. So I encourage you to try it. And I'm going to ask one more time to see if there are any other questions.
I just have, Bud, again, I just have, before we leave, I just think you all are doing an amazing job with this grant. And I will work on my end to continue to spread the word about this resource. I look forward to continuing to be involved. So good job. Good job.
Thanks, Bud. We really appreciate it.
Thank
we really
you.
appreciate it. Thank you. Well, if there are no more questions, then I thank you all for attending the inaugural Merge Grand Rounds, and hopefully we will see you next month. Be well.
Thank you, Kalli.